then I'm really honored to have Michael Hayden here today to present for us first. He is really the man behind the study. And I think we can say not too much to say that it's thanks to him that this trial is happening, actually, because without his persistence and convincing arguments, it wouldn't be here. I met him in 2009, first time in Copenhagen. And I was really encouraged by his optimism and belief that SIGN was on the right track to develop something that could treat HD. And here we are many years later, and undoubtedly we are closer to the goal of finding something that may help HD patients. And Michael has dedicated so much time and effort through his entire career to the HD field. And today he will tell us why he has dedicated and done so much hard work to make the proof study a reality, because this drug has been through a long history, and I think he will share something more about that for us today, and why he has this strong belief, I think, in the need to test Pridopidine also again in this trial. So please, Michael, I hand over the screen and the microphone to you. And please say a little bit more about who you are. You're not just the man from Copenhagen in 2009.
Well, thank you, Astrid. Thank you for that generous introduction. I too remember meeting you and Sven Olaf in Copenhagen. It feels like eons ago. And I think the message of today is that this is the trip, the journey of discovery leading to some treatment for Huntington disease is not a short trip. It's a continuous journey and one in which we all need to work together so profoundly as we have in an effort to really bring hope to fulfillment. And I think very importantly, I have recognized for many years that sick people with Huntington disease depend on us. And they depend on us to bring some hope and some reality into the possibility that a different future is possible. And I want to share with you just a little bit about my own past, because this has impact on why I've had a commitment to Huntington disease now that goes over 40 years. So where my journey began, I was born in South Africa and started seeing Huntington patients in the mid to late 70s. So really 40 years ago, actually 45 years ago, as a medical student intern. And I started seeing patients who were often disenfranchised by apartheid by virtue of the color of their skin, but were also disenfranchised by families with Huntington disease. And by the way, I have full permission to show this. This is a man with Huntington disease and his family. And in the back room was a young daughter who also had the juvenile form of this disease. And I was moved by the lack of knowledge. I was told that Huntington disease didn't exist in Africa. And the more I did home visits, and I saw about 1,000 patients and visited them and heard their story, I realized that sadly Huntington disease existed in Africa, and certainly in the population of European ancestry and mixed descent was probably the same prevalence as seen in the rest of the world, particularly in Western Europe. So I spent time with these families. These were families with not of any wealth, but I was moved by the wealth of generosity and warmth and spirit that they showed me. You can see this is a long time ago because this is what I looked like then. And clearly there've been changes. This was a family. She was looking after, Mary was looking after 3 children with Huntington disease, a sibling, all in the same house. But there was still time for sharing. I was moved by their dignity, courage, and the hope that they also exuded. Then, for all kinds of reasons, I was going to leave South Africa, and this woman played a big role in my life and actually got me into the United States. And this was Marjorie Guthrie. Marjorie Guthrie, the founder, what is today HDSA, and Marjorie became a huge force of inspiration and hope, and actually helped me to get into the United States. And Marjorie always, she introduced me to Woody. As I had my first child heard the songs of Woody Guthrie because they had come to me from Marjorie, and everything was about love and peace from Marjorie, and Marjorie became a major source of inspiration. So I would say what started as a journey of the mind, which was intrigued and trying to see whether Huntington disease exists in Africa, became a journey of the heart. And it was a journey of the mind and heart that led me to really believe that we've got to continue to do everything we can in an effort to bring some hope and some, not just hope, but fulfillment in an effort to try and change the outlook for families and patients with Huntington disease. So just trying to move this along. So I went from the University of Cape Town, where I went to Children's Hospital in Boston after that, and then came from the Brigham and Women's to UBC, and then was given the opportunity to also continue to Teva, where one of the conditions of me going there was that we were going to work on Huntington disease. I would say nobody in this pharma had heard of that disease, and we were able to do additional work, get appropriate investment. And from that, when I left Teva, I was able to take the drug that I'd seen some hopeful signs to Prilenia and continue that work. So I would want to say, whilst we do give hope today, it's important, and the hope is that it appears we have a safe drug that appears to act on a particular target. It has good tissue penetration. It's really, the outcome has been accepted by the regulators, and it's a meaningful outcome in terms of progression. And yet we have to maintain balance. We have to maintain balance because this is a trial, phase 3 trial. If you look at mostly 30% of phase 3 trials fail. And so there is still a reasonable chance of failure despite everything we've done to make this the highest possibility of success. So I think it's important to maintain that balance and realize that, of course, this is a long journey. And from the time the gene was discovered to therapies that have impact on progression as measured by clinical outcomes represents still a major challenge for us. Now, there's only 2 drugs approved for Huntington disease in the United States. And as part of my own commitment at Teva, we were able to take this drug to approval in the United States, which was the treatment of chorea. And this is Austedo, which was the second drug ever approved for Huntington disease, but also reflected, again, the ongoing commitment to this, to do whatever we can, even if it was just to treat chorea. As we look forward, of course, you all know, we've realized more and more that this disease affects a lot of people, about 100,000 people in the US, Europe, and the rest of the world. For every person affected, there are 3 people who are destined to be ill, but not yet ill. So total of 400,000 people, if you look at all. These are the only 2 treatments approved in the United States, tetrabenazine and deuterated tetrabenazine for treatment of chorea. Of course, the tragedy is it's genetic. As you witness what you see in your parent, you recognize there's a chance that you may suffer the same fate. And the symptoms often manifest long before diagnosis with some changes in personality and then going on. This is the drug. Chorea is what Austedo and tetrabenazine has impact on. But what I was really hoping to have some place, bring some hope, is to have impact on functional capacity. Functional capacity meaning people's ability to stay independent, to continue working, to manage their finances, to take care of themselves, to be able to walk with their children and grandchildren, to have longer life filled with meaning and without the disability. The drug that we're looking at is an investigator drug. It's also been chosen to be one of the first platform trial in ALS. I'm pleased to say, firstly, it's safe and tolerable. So they do not appear to be thus far, still the trial is not done, but appears to have a side effect profile similar to placebo from other trials. It's administered orally twice a day, and the drug has been shown in the past to potentially show maintenance of total functional capacity, but this is now the trial that's really assessing that. We know the mechanism of action precisely. It binds and activates the sigma-1 receptor, and there's some preliminary data that from open label where patients are, they're on the drug, that this effect may be prolonged, certainly up to 5 years. And just to show you, we can view the sigma. How did we know? And this was the new biology. How did we know where this drug works? You can label certain areas of the brain. We had some data to suggest that it might be binding sigma-1. So you label this and give this to humans, and it's radioactively labeled, and you can see the drug goes to all regions of the brain. That's this, and this is fluspidine, which binds sigma-1. So this label is an active ligand for sigma-1. Then you give your drug and you see how much of it is blocked, standing in the doorway to prevent it. And what you can see remarkably is that it appears to completely block or nearly completely block the radioactive labeled sigma-1 binder, which tells you that our drug is acting on that particular mechanism, and that's very important. This particular drug, when it does activate, we know this from other studies, we're assessing it in this study, it is neuroprotective. It reduces stress, it reduces inflammation, and enhances energy production, neuronal function, it's protective, and also clears toxic proteins, all things that are good and might be expected to show a good outcome. We've already shown in neurons from animal studies, these are neurons dying in Huntington disease. What you can see here, this is cell death. And here you can see in wild type neurons, these are normal neurons, you get about 15%. In the Huntington neurons from areas of the brain that are affected, the death rate goes up dramatically. And when you treat with this drug, these are animal studies, so these are not human studies, but you can reduce cell death. And this approach has been replicated in many, many different studies. It appears to enhance neuronal viability, and that becomes very important. The drug has a long safety record. It's been in 1,300 patients for more than a year before this study. And in Huntington disease, about 1,000 patients. And we know that long-term safety appears at this point to be comparable to placebo. That's very important because, of course, you don't want to cause harm in any patient on a trial. At the moment, this comes from BioCentury. This is the only drug in phase 3 for any trial in Huntington disease at the present time. So here's Pridopidine, Prilenia. There are numerous other drugs that offer hope for both Huntington reduction, psychiatric symptoms, also neuroprotection. But we are the only drug currently, and I'm not proud to say that, I wish there were more, in phase 3 for Huntington disease. So, and this trial will read out in the first half of next year. So this particular trial is designed to replicate data from prior trials which potentially showed a beneficial effect on functional capacity. And we fully enrolled, and essentially these are the investigators. Today you will hear from my esteemed and wonderful colleagues, Ralf Reilman and Ann Rosser. Ralf is the founding director and CEO of the George Huntington Institute in Munster. And Ann is a chair and professor at Cardiff University and chair of the EHDN. My North American colleagues are Andrew Feigin, who is on the line on the Zoom, and Sandra Kostick. And Andy is the chair of the Huntington Study Group that is really leading the clinical research in the study together with TFS in Europe. So I thank you for this opportunity to provide some background and really hand this over now to my colleagues, Ralf and Ann, to continue to give more details about this study.
Thank you so much for this introduction and for taking us back and also into the future, Michael, or into at least today. So Anne Rosser, professor in neurology, as you said, at Cardiff University. Hello, Anne.
Hello, Astrid.
There you are.
Hi.
I just hand over to you to continue the presentation together with your colleague, Ralf Reilman.
Okay.
So welcome, both of you.
Thank you very much. So Ralf and I will do a double act here, and thank you for that fantastic introduction, Michael. So as you've heard already, Pridopidine is, well, it stands for, Proof HD rather, stands for Pridopidine Outcome on Function in Huntington's Disease. So this is a phase 3 trial, which means that it's a trial that's seeking to establish whether Pridopidine is effective. It's a double-blind placebo-controlled trial, which means that both that participants in the trial may be taking drug or may be taking placebo, and they won't know which, and the investigators don't know which. And this is a very important part of running good clinical trials. It's taking place in multiple centres across North America and Europe, and I'll show you something more about that later. And it's in early stage Huntington's disease. So the key outcome measure in this study, so this is the measure that's used to formally determine if Pridopidine is effective or not, is the total functional capacity, which is shortened to TFC. And so why use the total functional capacity? Well, there are a number of reasons for this. So the first is that we know that function is a major issue as far as HD families are concerned. And this came out strongly from an FDA study published in 2015. And participants themselves, HD participants, strongly emphasized the problem of HD, which leaves them unable to perform many normal everyday functions that they'd like to perform. And of course, this makes people increasingly dependent on others for care as the disease progresses. So the TFC scale is designed to measure change in capacity of a whole range of everyday activities, such as being able to work, performing household duties, eating, dressing, etc. And it was said by Karl Kibertz, who has a huge experience in these sorts of trials, that any beneficial effect in the TFC would be considered clinically meaningful. So again, as you heard earlier from Michael's presentation, there's also some prior evidence that suggests that Pridopidine may be able to maintain function in Huntington's disease. And this is based on analysis of a previous phase 3 study, the Pride HD trial. And what you can see here is measures, this is measuring the change in TFC from baseline. So this line along here is the baseline. Anything upwards of the line is reflecting improvement. Anything below the line is reflecting deterioration. And what you can see here is that... And
baseline, sorry, Anne, for interrupting. Baseline is the starting point of the trial. Am I right?
Yes, quite right. Sorry, I should have said that. So baseline is the TFC measure when patients enter the trial. And you can see this grey bar here shows that the participants who turned out to be on placebo had deteriorated on average by about 1 TFC point per year. And that may sound small, but the TFC maximum reading is 13. So it's actually 1 point change does matter. And the individuals who were taking the Pridopidine, 45 milligrams twice a day, you can see that the levels of function hadn't really changed since the baseline. So this also illustrates another important point, which is that we wouldn't necessarily expect people on Pridopidine to start getting better and improving, but the hope is that it would reduce the rate at which people decline.
Yeah, I guess I will take over from here, and thank you. Hello, everyone. My name is Ralf Reilman, and as just introduced, I'm the PI for Europe of this study. And at George Huntington Institute, we have lots of people in this study here, so we are heavily involved in the conduct of the study as well. As Anne has just mentioned, it was obviously, I think, very thrilling for all of us to see that the TFC measure showed a stable performance in the treated people. Just to put that into context, actually, I would like to add that we haven't seen this in any other clinical trial yet. So we have never ever seen an effect on the total functional capacity, which, as Anne just alluded to, is kind of summarizing the overall function that you guys in everyday life have and experience. So obviously very, very important. And it was quite intriguing to see this, I think. But when we thought about that, having, as also Michael mentioned already, having actually done a few trials prior with Pridopidine, it was interesting to ask ourselves, so why is there actually this change in TFC? Can we see something that explains to us why TFC is changing? Because, you know, everyday things you do that we assess on the TFC come from something, and they must somehow, if you have a deficit, relate from symptoms that Huntington's disease comes about with. And motor function obviously is one of those domains that you all know we look at in the clinic quite a bit. So all of you, I'm pretty sure, most of you at least, who are patients, are part of the Enroll HD study that we conduct to yearly look at you. And you will remember that we physicians, when you come to the clinic, assess your motor function, such as eye movements or gait or the level of involuntary movements to chorea, using a scale called total motor score, or the UHDS total motor score. One part of movements that we look at also is fine motor control, for instance, manipulating, how you're able to manipulate things with your hand, with your fingers. So we have you tap your fingers, you will remember that. The right and the left hand, we look at that. And, you know, these motor control features are important for everyday life. If you want to drink a cup of tea or put in milk in your tea or whatever you do, button your shirt and stuff, it's important that you have fine motor control and motor performance in general. So it may be indicative for us to understand why the changes of the TFC happen if we see also signals in other domains. So if you could just move the slide one forward, please, Anne. One surprise, actually, that we found out when we looked at the Pride HD data that we were just looking at in terms of the TFC, was that the total motor score in that very trial at the end of the study didn't show a change between the treated people and the placebo group. Importantly, we had, however, in previous trials seen benefits on the total motor score in two huge clinical trials, in the MIRM-HD and the HEART trial. The MIRM-HD was about 500 patients in Europe. Some of you may remember that. We've done it a couple of years ago. And the HEART study was done in the United States, was about 300 patients. And in both studies, there was a significant benefit that was actually robust, the same size in both of the studies when we treated patients with 45 BID Pridopidine versus the placebo group. So that's the dose we currently have in the Proof HD study. So interestingly, when we looked at Pride HD, we didn't see the benefit at the end of the study comparing to placebo, but actually what we saw is that all groups were doing better at the end of the trial, all groups, including the placebo group. Now, Anne just alluded that placebo group is the group in the trial that doesn't get the drug. So that was a bit strange, wasn't it? We didn't see, we saw a huge benefit in a group that didn't get the drug. So what's said down here is the TMS results of the total motor score possibly might be explained in this study by a long-lasting placebo effect, placebo response. Why do we think that? If you could move one further, please. Some of you, all of you that are in the Proof HD study now have already done the assessments of the finger tapping in a quantitative way, moving away from the physician rating whether your tapping gets more regular or not in a subjective way. We have actually in the HD community been able to develop, with the support of CHDI and many colleagues, objective measures that we try to apply in clinical trials. One of the objective tools that's used a lot in clinical trials was used in Track HD and many other trials like Amaryllis, Legato, and so on, is the Q-motor. That gives us the opportunity to look at, for instance, the finger tapping on a force transducer in an objective way, as depicted on the right of the slide here. So rather than just categorically saying somebody is getting a little better or more better or something like that subjectively, we actually measure objectively the performance of patients in all sites in the same way. If you could go to the next slide, please. And if you look at those objective motor data that we got from the Pride HD study, interestingly, what is depicted here, you can see that the line below here, the lower line, that's the placebo group. The placebo group goes down. So from baseline to the end of the trial, people advance, they have more motor deficits. That's exactly what we have learned from all other studies where we used Q-motor. That's also what we actually see in non-treated populations normally, like in Enroll HD. We see there is progression, not as the rate is suggested in the TMS improvement. So, and then you see that if you look at the people treated with 45 BID, there is actually improvement and maintained difference at the end of the trial. That's significant at multiple visits. So that was quite interesting. In the objective measure, looking at motor coordination, important hand motor function, we saw a significant benefit with Pridopidine, which could somehow also partly at least explain why the TFC has been improving and gives additional evidence for us to believe that it's worthwhile doing huge clinical trials and supported the development of Proof HD. And if you want to continue, I think was the next one.
Okay, that's great. Thanks, Ralf. So coming back to the Proof H study and where we've got to, as you've heard already, it's a phase 3 double-blind placebo-controlled trial. It's fully recruited. Just under 500 people with early HD have been randomized to receive either Pridopidine, 45 milligrams twice a day, or placebo. And as mentioned already, the primary objective is to understand whether Pridopidine is effective by looking at functional decline using the TFC at 65 weeks. That's 65 weeks of patients being either on Pridopidine or on placebo. So then the people who have completed the double-blind study will be offered the opportunity to enroll into an open label extension study, which you'll often hear us refer to as an OLE. And what this means is that everybody in that phase of the study will be given the drug. So nobody receives placebo at that stage. And this is quite a common phase for phase 3 trials. So this is just really illustrating, these are the sites, 29 sites in Europe, and you can see going as far south as Spain and Italy and as far east as Poland, and almost the same number of sites, 30 sites right across North America in both Canada and the USA. So those of you who are on the Proof study will be familiar with this. This is just showing a participant's journey throughout the study. And so here's the start, and you can see that people will either have in-person visits or phone visits, and that during the whole of this journey, participants will be taking either Pridopidine, either the drug or placebo, right through to the end of the study, week 78. There's an end of study visit, and at that stage, participants will move into the OLE that I've mentioned already. So,
yeah, and it's actually quite remarkable, one has to say, and big thank you, I think, to everyone in the study who's present here today. That first of all, we had this huge dynamic in recruiting the trial so well. We actually over-recruited, so we overcame the target of 480 patients by nearly 20 patients. we were very quick. And also in the maintenance of the study right now, as Michael also alluded to already, it's great to see that we have a very, very high rate of patients that maintain stably in the study. Very few subjects discontinued the study so far. I have to say that having been part of prior trials with Pridopidine and knowing the safety profile, I'm not too surprised about this, but it's still great to see. And it's something which in some trials has been different in the past. And I think speaks to the fact that the tolerability also is something which encourages us to believe that this drug could potentially be used over years, maybe decades, which maybe what we want to do if we show the efficacy, if we reproduce the efficacy on the TFC, and could potentially even be, because it's well tolerated as it seems so far, used in people earlier than the cohorts we are studying right now. We'll have to see. That would be a hope, of course. So we still have 482 patients in the study, 97% retention. That's pretty unique for an HD trial, for particularly of this duration, because many trials in the past have actually been shorter and not gone for more than a year. So the last patient was recruited in October 2021. And by the way, apologies to some of you who might not have been able to get into the trial anymore. There were lots of people interested, but thank you for participating and giving us the opportunity to soon have the knowledge whether we can actually bring Pridopidine to everyone then if it works. So 50% of the patients already finished the 60 months benchmark. And you know, we are actually advancing with the first patients, just translating now to the open label study in the United States. The study started a bit later in Europe because regulatory startup takes a little longer here usually. But the recruitment, as I said, was very dynamic, and all the data so far suggests really well the safety, and the DSMB, as just suggested, has also recommended to continue the study as is. So with all the efforts in the trial that were so far put in by the whole team, I think it's really great that we are moving towards the point where we will learn about the result of the study. It's not that far anymore. We expect results in the second quarter next year. The study should be fully completed in the first quarter next year. And then by the second quarter next year, we will know the results. And thank you very, very much, everyone, for being part of the trial, for staying tuned, for the effort. I think it's a huge opportunity for us to test this. As Michael said, only phase 3 drug currently in Huntington's disease on development, which is an oral drug and doesn't have a lot of issues to deliver. If it delivers in the end point, I think we have a huge opportunity here. Thank you for the attention, and everyone I think now is happy to give you answers to questions you may have. Please, please, please do ask questions. Do it in the chat or ask it live. We are very, very happy to address your questions, whatever they are. Thank you.
Thank you so much. Thank you. Exciting and very interesting. So we have organized a panel. So in addition to those of you who have spoken and presented already, Michael, Anne, and Ralf, we have, I'm really happy to welcome Dina De Souza. She's from an HD family. Dina, can you just quickly say a little bit more about who you are?
Hi to everybody that I know and the ones that I don't. My name is Dina De Souza. I am a board member of the European Association. And as Astrid said, I am a family member myself. I have been involved with a lot of different things in the last 14 years. I have participated in as many studies as possible. It's the way I feel a little bit in control about my life. I am also part of the Scottish Association. I live in Edinburgh. I know I don't have a Scottish accent. And I'm very pleased to be here today. I actually have a few comments to make, but I will hold off on that. And
great. No, I would just want to introduce Andrew first, and then we can get started really with the discussion and the comments, Dina. So thank you for being here, really. Andrew Feigin?
Hi, everybody. My name is Andy Feigin. I'm a neurologist at New York University in New York City. I've been involved in Huntington's disease clinical research my whole career, and I'm the principal investigator for North America. And I'd like to thank our speakers today for doing such a terrific job, and thank you all for attending. And we're available to help answer questions about the PROOF-HD trial.
Thank you so much. I think I will start kickoff because I see there are coming in some comments now in the chat, but I think I will open the ball, so to speak. So Dina, coming from a family and yourself being so closely involved in all of this, you definitely have made some thoughts about this trial, and what are your general impression or thoughts about what you hear?
I am very excited about this trial because I see this trial as being baby steps towards having something that will help HD patients. And Astrid, as you know, I always say I never like using the word cure for HD. I am sure there will be a cure at some point, but at least in my lifetime, I don't see that. But having something meaningful that will help people with their daily tasks on a daily basis, I think is remarkable. It's a huge step. I know that everybody, the HD community was all geared up last year with the other trials. And yes, if there was a positive aspect to those would be phenomenal. But I think daily life or daily outcomes of your life are probably more important to people who are living with the symptoms. And this is going to add something, if we get the results, which I'm hoping, and it does look like, to have an alternative to what was already planned.
Thank you. Michael, I wonder if you could elaborate a little bit, because you were talking a lot about the TFC and stuff like that, but can you say a little bit more about what is it, because you also used the term neuroprotective. What is it about Pridopidine? What is it really doing? I mean, to make the cells work better, if I understand you correctly?
Well, Pridopidine is acting at an important junction in the cell. There have been drugs in the past that have had some impact on sigma-1, but they've had impact on many other targets that have negated or mitigated the positive effects of Pridopidine. What's quite unusual about this drug is its high selectivity at this dose. So it acts predominantly on sigma-1. And how do we know that? We know that because when you do animal or test tube experiments and you remove one of the 20,000 genes we have, just removing sigma-1, you see the effect is completely lost. So it's directly dependent on one gene, which is sigma-1. So that's an important point. That sigma-1, we now understand, has big effect on numerous actions and biochemical responses that are protective against cells. It acts to increase what we call neurotropic factors. These are things that promote cell viability for neurons. It enhances the reduction and removal of toxic proteins. That word is called autophagy. It improves the spine. So quite remarkably, you see this in animal studies where the spines grow and show more connectivity. It reduces stress, particularly this particular target is located close to the mitochondria, which are the power source for the cell, and it enhances mitochondrial function. So it has a whole host. It's a junction, it's a hub that then has a lot of downstream effects. And we do know from in vitro and in vivo studies that the effects of Pridopidine are directly dependent on the function of the sigma-1.
And in vivo and in vitro?
Yeah,
Sorry.
in vivo meaning being animal studies, in vitro meaning cellular experiments, not the full animal.
Thank you. Thank you so much. So
Astrid, can I make a
multiple
short
processes,
comment?
really. Yes, please.
You know, I think actually being an investigator and having had myself involvement in clinical trials for more than 30 years, there's one thing that I think is really special about doing these trials with Pridopidine now, that I see is very unique and an opportunity for the HD community. And that's that a lot of what we are doing right now, including the design of the clinical trial, is actually data-driven. And that's something that was difficult in some of the other approaches we have recently taken in the HD field that Dina alluded to or referred to. I mean, we have the privilege here, and that doesn't happen very often, that we, on the one hand, as Michael reported, have a lot of information about what the mechanism of this drug is in cellular models and animal models that were genetically created to answer questions very straightforward. But we also have human data. Michael reported about the PET data that shows that this target is really there in Huntington's disease, and it is involved by Pridopidine. So Pridopidine works in the brain of patients, in the brain of human subjects at this receptor, and that's very good. And we had the previous data, the TFC, the TMS, the quantitative motor data to support the design of this trial. It's pretty unique. So if this is successful, we know on the one hand, there is a huge history of safety, as we have already alluded to, because we've done it for multiple years, particularly with this dose, multiple trials. And if we can now prove the efficacy, it will be an interesting story to look at, because it would really be something that we would have done based on prior knowledge, not just in animal models, but really in humans. And let's see where we are in a year. Obviously, with all of you together, I think, keep my fingers crossed that we have an opportunity here for improving Huntington's disease. But I think that's interesting and remarkable, because it's not always there.
No, thank you.
And I think what is important is to encourage people to stay in the study and making sure that they stay in, so we're able to get the data that we need to answer this important question: does it work or doesn't it? So we want to encourage people to stay in the study. We can't do this without you. And so we're inextricably bound together, the patients and families, together with the investigators, but together, hopefully we can get the answer that we need to know within 10 months from now, something like that, not very long. So we're very grateful that people have stayed in the study, and we want to encourage you to continue to stay in.
So Andrew, maybe I can ask you, why 78 weeks? Because Michael said you need to stay in, which we all realize is important. Why this duration? Can you explain a little bit more about that for us? Why is that important?
Yeah, thank you for the question. As Ralf alluded to, the way we've designed this trial is really data-driven, based on data from prior trials. And so as has been presented, we know that the primary outcome measure for this trial, this measure called the total functional capacity, or TFC, tends to decline at around a point per year in the population of people that are participating in the PROVE-HD trial. And there's that's a mean rate of decline of about a point per year with some variation around that. And based on that number and data from prior trials, we determined that if we go a little bit longer than a year, the actual primary outcome measure for the trial is actually at 65 weeks, but people who are in the trial will go all the way out to 78 weeks until the last patient finishes to 65 weeks, basically. But in terms of efficacy, the first thing that we're looking for is what has happened to everybody at 65 weeks. It was determined that would be the optimal length of time, again, based on data from prior trials and based on what we know about the total functional capacity.
May I make a short comment to that, Andy? I think Andy summarized this really well. And the importance here is that we actually ask you a lot. We are aware of this. I think we are really aware of this. You have to stay for a long time in the study, but it's for a reason, because the TFC only changes very slowly in a way. I mean, and sad, it's going to be like, 1 point per year, and we only have 13 points on the scale, but the change is over years and decades. We cannot do a clinical trial that takes 5 years. So that's why we have a large number of subjects in the study. So we asked 500 people to be in the study, and we only have 1 dose against 1 placebo group. So we can get a clear answer with, as we call this in the science, is a high power. So we have a good chance to really detect the effect. And we were really discussing with Prilenia and with everyone in the community, how long can we go? The initial trials with Pridopidine were only 3 or 6 months. That's also why we didn't see other things changing. Now, with the PRIDE study, having done it for a year, we saw the change, and we want to, improve our chances to bring the drug to you by detecting the signal that then convinces the regulatory agencies to give us the chance to use the drug. And that's why we ask you for your patience and to hang in there and to really go to the last visit. And by the way, what Andy just said is right. We go for this 60+ weeks, but we will use all the data for the longer period as well, in the subgroup of people that go for longer, to get this additional evidence to see whether there is an even bigger change at 70+ weeks. So that's why we ask you to do this, and that's why we need you to stay in the trial. We didn't want to torture you with a longer trial, but it was really driven by the science and by the previous knowledge from other trials, by all the help actually you gave us, the data from Enroll HD, for instance, which informed.
Thank you, Ralf. Because I really think we should use some minutes now from picking up from the chat. So please, Philippa, if you can help us. And Anne Rosso, we haven't addressed anything to her. She's also here, so maybe we can ask her something.
Both Joshua and Siobhan ask if would there be any benefit, assuming that the study continues to go well, for asymptomatic HD? Will there be another clinical trial to assess whether this works in pre-symptomatic HD? So this is the first question.
So maybe that goes to Prilenia, Michael, I don't know.
Well, of course, I think Anne could also answer this, but the answer is yes. I mean, we will get an indication if we are successful for treatment of Huntington disease, but I think there will be a need for another trial to show it's a much bigger population, people destined to be ill but not yet ill, and it's a much more difficult trial because you then have to have some endpoints where there are changes. And we're in the early stages of thinking and planning for a study that looks at the at-risk population. Because, of course, the earlier you treat, the better, because you want to treat when the cells are still viable and they haven't died. So the earlier you go, the better. And we do know, sadly, that even before people have onset, there's already significant changes in the brain. So we'd want to treat earlier. But we would probably have to do another trial to prove that.
And when you say endpoint, Michael, it's really how you measure an effect. Yeah.
So you'd have to, obviously, imaging, other biomarkers. There are now advancing knowledge about things in blood that may predict further deterioration, and these may occur early, has already been shown. So these are blood levels of certain products that are released from injured neurons that are seen in the blood even before anybody has symptoms. So these haven't been validated. There are lots of issues around this, but a new study would be best to prove that this works.
So Michael, to target pre-manifest people, you would not be able to use the TFC because those group of people will have a TFC of 13.
That's right. That's exactly right, Dina. Exactly. You're spot on. Correct. But there'd be other things to use. There are imaging things, imaging modalities that we know detect very early findings. There are biomarkers that detect. There are even, and Ralf could comment, even Ralf has shown already some subtle motor changes in people destined to be ill, but not yet with the diagnosis. Maybe, Ralf, that's one example of something else, but TFC we could not use as an endpoint.
Yeah, it is actually, Dina, one of the things why we were looking for years in the Huntington community to developing more sensitive, also clinical measures to allow us to assess the effects of drugs in the prodromal pre-manifest phase. I mean, many of you all listening here know that the transition is a very, very slow and long one. And I think we need to be able to assess this. That's what we want to do. And that's what we've been shown we are able to do, for instance, with, as Michael said, imaging, biomarkers, but even with things like Q-motor, you can detect a slow, very slow progression of issues that we can measure, and it may allow us to measure treatment effects. That's why all these efforts, including Track HD, were extremely important to us, I think. The opportunity may be there to do a trial. Once we prove that it works in the cohort we now study in the symptomatic patients, we can move it too early. And I think there was a question in the chat also, of course, we could also try and move it and would expect that it might also have some efficacy in later stages of the disease, which are currently not included in the trial. We'll look at that for sure once we have proven that in Proof HD there is a signal.
And then just to add one point, if, by the way, it's a big if, it's the big ultimate if we show the effect in early HD, we'd also want to look at other tremendous unmet needs, like juvenile HD. Children who have, in this trial, it's only people over the age of 25 who are in the trial. Well, would we expect to see something in younger patients, particularly for a safe and tolerable drug? So that would also be something to concentrate on as part of the future.
Thank you. Really exciting. And then there are a lot of more things that can be done. But before that, it's this trial. And Anne Rosser, I would like to bring you to this panel also and ask you, could you explain to us in broad, what would be next steps next year if we hear that there are positive results? What's happening then?
You mean if the trial proves efficacy?
Yeah, or not. Maybe you can outline both.
Well, yeah, so yeah, very good question, Astrid. So I guess the first is the one we would most like, which is that the efficacy signal is proven, in which case, you know, one would need to go to the various regulatory bodies to try and get this, you know, prescribable effectively by physicians. And I'm sure Michael would be happy to say a bit more about that. I know this is something that that he's given some thought to already. I think, you know, the harder one is if for some reason that the efficacy signal isn't there. And I was just contemplating while we were having the discussion about, you know, looking at pre-symptomatic individuals. It's not necessarily the case that if we don't see a signal in the early HD, it's not necessarily the case that it wouldn't be beneficial in pre-symptomatic HD, but that's a very difficult one. I don't know, Michael, whether you have any comment on that and whether there'd still be an appetite to look at pre-symptomatic HD if the current trial doesn't meet its primary endpoint.
Well, there are three outcomes that could happen with this trial. Success on the primary outcome, that's what we all would hope for. A negative outcome where there's absolutely no signal, or a gray outcome where the statistical significance is not reached, but there are trends in that direction. And so it warrants, and there's some reasons that there are some patients who didn't do well. Maybe there were patients in very early who did well, but intermediate did not. That would then necessitate additional studies. If we were to show, for example, it did very well in the earliest patients, but not those who are going on further, that would give you strength to do a pre-symptomatic trial, because it says, you know, I don't want to put an analogy, but just to put something completely different. If you think about a fire in a house, which is really what's happening with neurons, and you want to treat them early, when you go late, it's hard to prevent that further terrible outcome. So you want to treat early as possible, and it'll depend on the nature of the results to decide the next steps.
Thank you. Philippa, anything else from the chat we should pick up on before we close?
Essentially, it's about the impact of this treatment. So what specific symptoms is it expected to help? Chorea, personality changes, cognitive changes, coordination, or how does it work on cognitive and psychological aspects of HD? So these are some of the questions also.
I would just to answer that quickly is that we don't yet know. We do know that you can protect neurons. We've seen that in all the animal and cellular experiments. We would expect that to show some effect on a whole host of symptoms. The one aspect that it will not treat is chorea. We know that. And chorea is manifest with a totally different mechanism. It's a dopamine mechanism, and all the 2 drugs that are approved decrease dopamine levels in the neurons, whereas this drug does not. So we don't expect to see improvement in chorea, but the good news is you can use it with a drug that is used for chorea. And also this drug could be used hopefully with other drugs that lower Huntington, for example. This would be a good combination of therapies, as you see in many other serious diseases where different drugs with different mechanisms can work together to have potential additive or maybe even synergistic effects, which is even better than that seen in additive. So we don't know. There's a lot that we'll have to review to decide the next steps.
So can I just ask then on what your comments there, Michael? Is this, it being a neuroprotective, is the reason why it's, you are also doing it in an Alzheimer's, or not you, but it is a drug that is potentially going to be used in Alzheimer's, the neuroprotectiveness of—
Well, this is a drug, without going into too much detail, the mechanisms associated with neuronal death are the same for Huntington's, ALS, Alzheimer's, Parkinson's, and some very rare disorders. So if we were to show this, Huntington could be the model for some protective effects that could offer hope for other diseases that are part of neurodegeneration. And this is, neurodegeneration is the upcoming and current new pandemic. You know, the impact on the economy and on lives is so profound. And so, yes, this has a chance potentially to have much broader application beyond Huntington disease if we're able to show it in this disease. Much to be done in that scenario.
I have—
Thank you. Yeah, you have still one?
the last one. So will there be any trials in other regions other than the US and Europe?
Currently, to get approval, we're in the major areas that get approval. We would generally, in each country, it's a little different. But if you get approval in Europe and the US, many other countries in the world will accept that approval as allowing approval in those other countries. So we will be working. I think there's a commitment from Prilenia to making this accessible for people around the world, if successful. This is, of course, all on the basis of success. I just remind you, there's a 35% chance of not success, so we need to bear that in mind. But if successful, we would do everything we could to make this universally and globally accessible for patients everywhere. And in each country, it's a little different. But in general, if you get approval in the US and the EU and the UK, a lot of that is a big step to approval in other countries.
Thank you so much, all of you. Andrew, I think I want to ask you the last question, because you are chair for the Huntington study group, and you are really doing all the operational things in conducting this trial. And what is it? Because we've heard this is a successful trial. What factors is most critical, do you think, also for future trials, to ensure to be able to recruit fast, have people stay in and deliver results?
Well, that's a great question. Thank you. I think that there are many factors that play a role in how quickly trials recruit and the ability of trials to keep people in the trials. I think from my perspective, among the most important things are the relationships between the sites, the site investigators and coordinators and site staff, and their patients and their families that they take care of. And in addition to that, the relationship between the site staff and the coordinating organization, in this case, the Huntington Study Group. The Huntington Study Group has been at this for almost this kind of multi-center clinical trial for almost 30 years. And so we have very good established relationships with sites, with investigators and coordinators. We work on that, and we also tend to want to work with sites that have good relationships with their families and their patients. And so to me, those are the key things, the relationships actually. And I think that explains why we're able to recruit quickly for this trial, 499 patients in a year during COVID, and why I'm very hopeful that we'll be able to keep people in the trial. So yeah, thank you for the question.
Oh, great. I couldn't agree more. It's a collaborative effort, so that we all see our contributions are important, equally important from all sides of that.
So can I just
multi-stakeholder? Yes, please, Dina, you can have more or less the last word.
Sorry, no, I'll give you the last word, but I just wanted to comment on Andrew's. The ADHD community and patients, families, carers, they are super ready for anything and willing to participate in anything. And enrollment is, I don't think, will ever be an issue for any studies. That's the way I see everybody.
Yeah,
everybody's ready.
I agree. I completely agree with that. And, I think, thinking about doing this trial during COVID, we were hesitant, but what you just said was proven correct once again. Yeah.
Fantastic. So then again, a huge thank you to all the people who have volunteered to be part of this study and other studies ongoing or in the past, and of course also to the site staff and to the to Prilenia and other companies who are doing this and really working hard to make treatment possible in the future for those who need it in Huntington's disease. So I just want to say thank you. And if you want to turn on your camera and wave to each other, I think that's nice, because we are isolated still a little bit during these post-COVID times. Thank you so much.
Thank you so much.
Thank you.
Thank you.
Take care.
Bye.
Bye-bye.